And now Professor Rayner from the Grotsure Hospital of Cap. Chronic kidney disease, new trends in the next coming 10 years.
Good morning, and thank you again for inviting me to this very important Congress. And I'm going to talk to you about chronic kidney disease in the next 10 years and perhaps give you a different perspective of prevention of kidney disease and cardiovascular disease. So one of the biggest problems facing the world is this major prevalence of chronic kidney disease, particularly due to diabetes, up to 40%. The really important issue is that these are the percentage of patients with CKD stage 3, but look at the percentage of patients with CKD 4 and 5. So in this period, you either die and a small percentage go to dialysis. And the majority of people are dying of cardiovascular disease. So prevention of kidney disease also may prevent cardiovascular disease. And it's also important to understand the natural history of chronic kidney disease in diabetes. We have a period where glucose is uncontrolled of hyperfiltration, which is mediated by the sodium glucose transporter 2, and then progressive loss of renal function with creatine albuminuria. But the same on the bottom axis, cardiovascular disease and cardiovascular disease are increasing remarkably. So kidney disease is actually starting here, when the GFR is elevated. And look at UK-PDS, progression through the phases is about 2.7. But look what happens here to death rates. If your creatine is elevated, you've got a 12-fold increase in cardiovascular death. And if you've got albuminuria, 3.5%. And if you have diabetic kidney disease, your life expectancy, if it's early, is 14.8 years reduced, and if you're a female, 16.9 years reduced. So why is this? So when you get kidney disease, you have traditional risk factors, but you have exacerbation of hypertension, exacerbation of cholesterol, and exacerbation of hypercoagulability due to the albuminuria. You have novel risk factors here, oxidative stress, inflammation, advanced glycosylation enterprise, and uremic-specific risk factors, for example, changes in the parathyroid gland and calcium and phosphate metabolism that leads to vascular calcification. A critical issue to understanding this is in this little organ called the glomerulus, which is actually a phenomenal engineering principle with the countercurrent mechanism. This has to be tightly regulated. This pressure, which determines GF, has to be tightly regulated. If not, the glomerulus suffers damage and leads to chronic kidney disease. And this is very illustrated, and the diabetic is particularly prone, and I'll show you later why. This is experimental animals. They induce hypertension in one kidney. This is non-diabetic, and you see there is kidney injury that happens slowly over time. But in a diabetic, you induce the same experiment, you get quite marked kidney injury quite early on in this experimental model. So pressure in that kidney is playing a critical role. And this is linked to the reabsorption of glucose in the sodium in the proximal tubule, mediated by sodium glucose transporter 2. And in diabetes, this is upregulated with increased glucose absorption and sodium absorption, leading to a fundamental plausible link between glucose control, hypertension, chronic kidney disease, and heart failure. This mechanism is critical for survival of animals and human beings in early evolution, because if you lost 720 calories every day in your urine, you would not survive. Similarly, if it's 10 millimoles, and this is absorbed, 1-to-1 with glucose. So that's, if you make it 10 millimoles, that's 1,800 millimoles of glucose, so additional 900 millimoles of sodium is reabsorbed, 60 grams of sodium chloride, and 12 teaspoonfuls of salt. Your normal intake of salt today is about 1 teaspoonful. This has phenomenal effects on the cardiovascular system and the kidney. And this is illustrated here that people with long-standing diabetes, the major endpoint in diabetes is heart failure, particularly long-standing. And you can see why this may be the case. So here we go back to what's called the tubular-glomerular feedback loop. Normally the sodium and glucose is reabsorbed here, and that's fundamentally preserved for survival of early humans. So 720 kilocalories. You filter 24,000 millimoles of sodium here, and 900 millimoles of reabsorbed by the sodium glucose trans. So remember, the hunter-gatherer had 20 millimoles intake. Our current diet is between 100 millimoles. So when you have diabetes, this is upregulated, reabsorbing sodium, decreasing your renin, increasing your blood pressure, increasing BNP, and increasing renal blood flow through that. The macular denser senses less sodium, so it activates the renin-angiotensin system and the tubular-glomerular feedback, resulting in afferent dilatation and efferent constriction. And this puts stress on the glomerulus, resulting in proteinuria. If you give ACE inhibitors, you dilate the efferent, reduce the pressure, and reduce albuminuria. But if you also inhibit a sodium glucose transporter, you constrict the efferent, further reducing the proteinuria and progression. And this is shown here, where you give an ACE inhibitor. This is the hyperfiltering diabetic, comes down to normal GFR. Hyperfiltering diabetic with a sodium glucose transporter, empagliflozin, reduces the GFR. And now we come to the studies. This is the landmark study where they get diabetics, high-risk diabetics, for cardiovascular events, empagliflozin or empagliflozin 25 milligrams. It reduced A1C because you're wasting glucose in the urine. It reduces weight because you're reducing calories. Reduces blood pressure because you're wasting sodium. Reduces cardiovascular death, but mainly driven by heart failure. And you can see the heart failure starts immediately because of the sodium loss in the urine. But more importantly, you also stop progression of kidney disease, a 39% reduction, doubling of creatinine, renal replacement rate reduced by 46%, initiation of dialysis reduced by 55%, and even if your GFR is low, because you also get this effect, because you think if the kidney is reduced number of nephrons, this effect wouldn't be so great. The effect on glucose control is less, but the effect on the kidney is preserved by these drugs. And this is illustrated when they did the eGFRs in the study. That's placebo. You get this reduction in GFR by adapting, going back to the basic principles. But in time, because now this glomerulus is much happier with the reduced pressure, these lines cross, leading to reduction in renal endpoints. And this, another study with canagliflozin showed a reduction in cardiovascular events and also regression of albuminuria and reduction in hard renal endpoints, 40% reduction in eGFR, end-stage renal disease, or end-stage death. And very recently, a dedicated diabetic kidney disease study called Credence, where they gave canagliflozin versus placebo, was stopped early in diabetic kidney disease because of superiority of canagliflozin. The study is not published, and I don't have any further details on that. But the relevance to chronic kidney disease, and this is where the future is that in chronic kidney disease, you also get hyperfiltration because the remaining glomeruli have to adapt and increase GFR. And the only way they can do it is increasing it by dilating the afferent, constricting the efferent. And we know ACE inhibitors protect the kidney by dilating the efferent and reducing proteinuria. But in chronic kidney disease of diabetes, if you add the sodium glucose transport inhibitor, because you're still filtering glucose, is this now going to be renoprotective for the future? And there are dedicated studies now, a whole raft of studies done outside diabetes, DAPA-CKD outcomes, looking at mechanisms, heart failure studies here, outside diabetes, So this really is potentially the future for the prevention of both cardiovascular and chronic kidney disease, the so-called cardiorenal effect. Now I'm going to change tack, and here, this is in Tibet, and anyone's brave enough to climb up to the top there, most people in this audience wouldn't reach the top, because you're at a massively high altitude. Now, we have erythropoietin, or ESA therapy, for anemia. And this has revolutionized anemia of chronic kidney disease. It's eliminated iron overload and transfusions. We can give it easily and important improvement in quality of life. But the more cardiovascular complication mortality, particularly push it, maybe cancer-related death, risk of hypertension, thromboembolism, hyperresponders, immunogenicity, and so on. And the higher your dose and lower your hemoglobin, that's where the cardiovascular risk happens. Those patients who are not responding well. Now, high altitude, there are several places in the world where you have high altitudes below 2,500 meters, where oxygen saturation falls to 60%. And human beings have to adapt to that. And you can see, if you live at high altitude, you use less erythropoietin, much less than at sea level, where I come from. And in observational studies, if you're on dialysis at high altitude, you have a 15% lower mortality. Now, this is observation. So now, how this works, if you've got increased oxygen demand or decreased oxygen demand, that prevents the breakdown of HIF. Okay? If there's lots of oxygen, HIF is broken down. But then HIF is stabilized. And you produce erythropoietin, you mobilize iron, which is a major problem in chronic kidney disease, you mobilize VEGF, you prevent apoptosis, and you mobilize glycolytic enzymes to adapt to the high altitude. Now you can block this, the protein hydroxylase, so it doesn't get broken down, and you can artificially stimulate this pathway. And as you can see, here's an inhibitor which will improve anemia, but the erythropoietin levels are not high. This is a once weekly injection. You can high erythropoietin, and if you give Aranesp, a long-acting erythropoietin, you've got very high levels. And remember, we discussed the issue that these high levels may be the cause of the adverse effect. And you can see this is these drugs that have been developed. This is placebo here. The reticulocytes go up. EPO levels don't particularly go up. The hemoglobin goes up. And you mobilize iron. Because in chronic kidney disease, you cannot mobilize iron because of the problems with increased hepcidin. And you can see the ferritins mobilize. The hepcidin, which is blocking this pathway, goes down. And importantly, the one worry is VEGF, because VEGF is not going up. VEGF could stimulate cancer. CRP stays the same, total cholesterol stays the same, and cystatin C, renal function, stays the same. And so if you look at the important things of these inhibitors, you raise the hemoglobin, but of course raising hemoglobin may promote thrombosis. You may promote angiogenesis to ischemic tissue, reduce retinopathy, but you may promote tumor angiogenesis and worsen retinopathy. You reduce hepcidin and promote iron, and increase iron availability potentially for pathogens. You may potentially increase the risk of pulmonary hypertension, and there may be some interaction with rheumatoid arthritis, but it's not well understood. So for the future, these studies, we know they raise hemoglobin, but are they safe? So there's a whole raft of studies undergoing now for non-dialysis patients, dialysis patients, and incident dialysis patients, where they're going to be treated with these drugs, and they're going to look for safety endpoints, and they're going to look for cardiovascular endpoints. See if they are superior to the current erythropoietin or alternative. And there's another range of studies, the same with a different PHI inhibitor, the same, we're dialysis dependent or non-dialysis. And I'm involved in 2 of these studies. So these studies will be available in the next 3 to 4 years, and will have maybe an important armamentarium for treatment. And this may apply to the cardiovascular field as well. As you know, patients with cardiac failure are also prone to anemia. So it may be a safe, where erythropoietin hasn't proven beneficial in heart disease. So in conclusion, the sodium glucose transport inhibitors offer exciting opportunities to protect the kidney in type 2 diabetes and other nephropathies now. We're waiting the studies. At the same time, protecting against cardiovascular stress, especially heart failure. And this goes to the fundamental mechanisms. And proline hydroxylase inhibitors may offer more physiological treatment of anemia of chronic kidney disease, with potential advantages on iron metabolism, and avoid many of the problems we face when we give intravenous iron. Thank you very much for your attention.
Thanks and congratulations. Est-ce qu'il y a des questions? Est-ce que nos diabétologues sont là? Non? Si, voilà. One question. Micro. Ah, vous avez une... Allez, ok. Voilà. Expert.
No, I'm not the expert, but I'm happy to see that the SGLT2 inhibitor you think it will work as well in a chronic kidney disease patient without diabetes. It looks like with the physiopathology of this drug, it will work as well from hypertensive chronic kidney disease or the other one.
Sorry, I didn't catch the question.
So the question is, you think that the SGLT2 inhibitor will work as well for the patient with chronic kidney disease without diabetes?
You mean late chronic kidney disease?
Yeah, but the one in people without diabetes, non-diabetic people.
Well, that's the point. Is the studies are now undergoing in non-diabetic chronic kidney disease, where this very similar mechanism is operative. But remember, the glucose is not elevated, so the effect may be less than in a diabetic patient who's uncontrolled. So the studies have started, and we're waiting for the next 2 to 3 years for the outcome of those studies.
Yes, but from the physiopathology aspect, you think it will work? Yes. I think the mechanism is applicable, but may not be as strong as in patients with diabetes when the glucose is elevated. Because remember, the influence on the tubular glomerular feedback may be less because the glucose is not elevated. Okay.
Micro.
Yeah, but it's still filtered, and it's still 700 calories, and it's still 900 millimoles of sodium, which will influence the tubular glomerular feedback loop. Yes.
And the last question here. The last one.
It was about the same topic, in diabetes people, inhibitors, SGLT2 inhibitors lower hemoglobin glycate by only 0.2%. So I think it means that it will work also with people without diabetes. And I think this molecule is no longer the property of diabetolog, but for all of us. Thank you.
Okay, thank you.
Thank you. Thanks.